Marion, good morning. Thank you, David. Thank you very much. I'd like to thank the organizing committee for this very nice invitation back to Toronto. So the topic is really stopping oral therapy, outcomes in terms of S antigen loss, flares, and retreatment. These are my disclosures. As you know, there are two clinical situations in which we can stop oral therapy. The first is after S antigen loss, with or without seroconversion. I will not cover this issue because this is standard of care, is safe and effective strategy. I will cover the second issue, stopping oral therapy before S antigen loss. And this has been really included in many guidelines, including the recent European guidelines, 2017, 2018, and there has been a lot of discussion on all the advantages and disadvantages of stopping therapy before S antigen loss. And I will not cover these issues, but just to make a point, that one of the possible indications to stop oral therapy before S antigen loss is really to achieve S antigen loss. And this is really the first part of my presentation. This is a summary slides of a systematic review that was published in 2016, looking at a very large number of studies and patients, 14 studies in initially antigen positive patients and 17 studies in e antigen negative population. Whenever we say e antigen negative, this is referred to starting when we start oral therapy, not during therapy. And overall, this systematic review provided the suppression rates of therapy, biochemical response, but please note at the end the pool rates of S antigen loss was really limited, only 1% for the initially antigen positive, 1.7% in the initially antigen negative patients, suggested that if you want to stop oral therapy before S antigen loss, to achieve S antigen loss, probably this is not the case. However, in the last 3-4 years, there's been several new studies addressing specifically this issue. This is a new summary of the studies available specifically in the e antigen negative disease, which is the more controversial. 3 European studies, some East Asian studies. You see on the top the percentage of S antigen loss of therapy, and on the horizontal line time. And you see clearly there is a progression of the rates for approximately 10% over 1 year, after 1 year of nuke stopping, to approximately 20-30%. However, you will see a significant heterogeneity of the results, with some of the studies of 5 years only 10% compared to some other studies up to 55% as antigen loss, suggesting probably that these studies are very, very heterogeneous. And indeed they are in terms of number of patients, liver disease, S antigen levels when they stop therapy from 1.6 logs to 4.7 logs. And most of the studies are retrospective. This concept of different S antigen loss rates if you stop oral therapy before S antigen loss has been recently confirmed by this review. Again, several studies, e antigen negative patients, 8 studies, you see the rates here. Different drugs, old drugs, new drugs, different patient population, different probably genotype, with rates going from 40% of 5 years to 13% of 5 years. Again, probably very heterogeneous studies overall. But not all studies are retrospective. And I think this is something very important. Most of the data are retrospective, but not all. On the left side, you see a very nice, very important German study, randomized control, 19 S antigen loss rates, building up after 24 weeks, a kind of stable situation after from year 2 to year 3. On the right-hand side, you see the Greek study is not randomized, but it's a prospective core study, only antigen negative patients, up to 29% S antigen loss at 21 months, but remember 5% were already negative, so at the end it would be 24%. But I think one of the most important new study is really this Toronto study, which has been recently published in GUT by Harry Jansen and co-workers. This is very important because while the previous 2 or 3 studies are suggesting that yes, indeed, you can stop oral therapy, achieve quite good S antigen loss rate, this is not the case by this study. Randomized control study, 67 patients nuke suppressed, stopping therapy, randomized to either stop therapy or continue therapy They were 92% antigen negative when they stopped therapy, but many were antigen positive at the beginning. 3 logs as antigen at the starting when they stopped therapy. On this left side, you see S antigen levels, DNA levels, ALT levels, and basically there were no changes in terms of S antigen decline if you stop compared to if you don't stop. Much higher ALT levels, DNA levels, and much higher DNA levels if you stop compared to if you don't stop. In terms of S antigen loss, only 1%. Actually, it was one case, 2% if you stop therapy, and compared to 4% if you do not stop therapy. So clearly suggesting that this is not working. At least in this population, 97% Asian patients, E antigen positive beginning. If you look for S antigen loss, probably you should not stop therapy. What about ALT flares, which is the second topic of my presentation, and there will be another lecture on this. ALT flares are generally defined as more than 5 times the upper limit of normal or above 10 times the upper limit of normal. There have been a lot of discussions, several working groups on the definition of these flares. This is a very recent working group with a paper which is now in publication defining on-treatment flares, resistant reduced flares, post-treatment flares, and this could be very relevant for the topic today, looking at the interferon studies. On the right-hand side, you see a very brand new data, again, from Dr. Liao, suggesting the possibility, once again, but in the setting of the stopping oral therapy in the antigen negative before its antigen loss, of a good flare and a bad flare. And what it's suggesting is that you should use S antigen kinetics at the peak of ALT to define whether this is a beneficial flare or a bad flare. I have to say, I don't see such a huge difference in these two cases. That could be my problem. And all these very sophisticated analyses are very good for academic centers, are very good for clinical trials, will not be very good for clinical practice. There is another very important point, is that flares are related to virological rebound. So according to the definition of virological rebound and timing of the definition, flares will change. But this is even more complicated because flares can be defined or increase of ALT in different ways, in different occasions. And of course, the number of flares or the number of biochemical relapse will change completely according to definition. And there is one more important variable, which is retreatment. If you retreat very early, you will not see flares. If you retreat late, you will see a lot of flares. Just to make a comparison, which is a sort of comparison, I merged the two studies, the randomized control study from Germany and the randomized control study from Toronto, to try to look at ALT flares. You see, in patients stopping therapy, continue therapy, stopping therapy, and continue therapy. You see that indeed there are significant flares in both studies, significant, more than 5 times the upper limit of normal. If I remember correctly, in this study, 49% of the patients had a significant flare. 2/3 of these had more than 10 times the upper limit of normal. And you see that what is surprising is actually the pattern of flare is apparently different from E antigen negative Caucasian patients to E antigen positive or negative Asian patients. This could be eventually interesting. Overall, 20 to 40% of the patients who will stop therapy before its antigen loss will have a flare, but there is no evidence of decompensation in these patients if there is no evidence of cirrhosis. But the issue of decompensation and risk of decompensation if you stop early therapy is a very important issue. This is again a very recent review where they look at the risk of decompensation in cirrhotics if you stop oral therapy or if you continue oral therapy. Some studies only from Asia, probably approximately 1% per year as a risk if you stop therapy, very limited. Between 1 to 2% if you continue therapy. This is surprising. We normally do not see decompensation while you continue oral therapy. So I'm not sure how we should interpret this data. What the point that we want to make in this study is that if compliance is very low, which is possible, then you see a decompensation even during long-term oral therapy. from my point of view, I would never stop oral therapy before S antigen loss in someone with a compensated cirrhosis, because I think safety is the very important issue here. The last part about retreatment, how do we retreat after stopping oral therapy before S antigen loss? There are no indication, EASL, ASLD, a puzzle to my knowledge. And there are two conditions in which we should restart therapy: because of significant flare, or just because you have persistent mild to moderate liver disease, like in naive population, abnormal LT, elevated DNA levels. So what I did, try to provide you a figure in terms of how many patients will be retreated if you stop oral therapy before S antigen loss. You see 4 different studies, the combined Greek and Taiwan studies, 40% retreatment after 24 months. In the German study, you have 40% retreatment after 3 years. In the Canadian study, 39% retreatment after 72 weeks. Taiwanese study, almost 700 patients stopping therapy before S antigen loss, 41% is very small character, but believe me, it's 41% of retreatment. So overall, despite all these studies are different for viral genotype, stopping rules, serology, retreatment criteria, whatever, at the end, 40% will be retreated, which is, of course, from my point of view, is a failure of this strategy to stop oral therapy before S antigen loss. But there is another very important point I'd like to make briefly, which is the relationship between S antigen loss, probability of S antigen loss, ALT flares, and retreatment. And this is data from Taiwan, again, a very large study in antigen negative population, because at that time in Taiwan, it was mandatory to stop oral therapy before S antigen loss after 3 years of continuous therapy. What they did in the study is that they compared 2 groups, A and B. A are those patients who had a clinical relapse and they were retreated. 0% S antigen loss. Group B, they had a clinical relapse, but they were not retreated. 18% S antigen loss at year 8, suggesting that you should not retreat too early to get some S antigen loss. But please note that actually the 2 curves are exactly the same at year 1, exactly the same at year 2, exactly the same at year 3. They start to diverge at year 4 only. So for short-term studies, you will never see this difference. And of course, cannot be too early, but cannot be too late to avoid any severe flare, life-threatening flare. And this has been suggested, confirmed by a recent review paper, again, by Dr. Liao. He looked at the e-antigen negative studies, 5 different studies. He looked at the S antigen loss in those not retreated versus those who were retreated. And for all these studies, the proportion of patients achieving S antigen loss, if they were not treated, is higher than in the second situation, again suggesting the same issue. What is unclear for me, for this paper, is whether they were not treated because they had no virological rebound or no flares, or they were left untreated despite a flare and despite a virological breakthrough. So when should we go for retreatment? This is a suggestion. Probably there are 2 conditions: severe flares. If you have a flare about 10 times the upper limit of normal, I would suggest we should retreat. The second condition is about 5 times the upper limit of normal, with some indication that the liver function is really worsening. The second condition basically is like in the naive population. If you have any evidence of moderate or mild or moderate disease activity, I would restart oral therapy. So ladies and gentlemen, to summarize this section, new discontinuation before S antigen loss. So I think there are significant heterogeneities among studies, very few prospective. To my knowledge, only 2 are randomized control studies. Yes, the option to stop oral therapy before S antigen loss to achieve functional cure is real. What we have to be careful is that apparently the percentage of patients achieving functional cure of therapy really is really dependent on many variables, probably, and the next speaker will cover this issue. This can go from 1% to 30%. ALT flares may be significant, but they are not associated to decompensation in the non-cirrhotic chronic hepatitis. But please, let me make a clinical issue. How do we define a non-cirrhosis during long-term nuke therapy after 20 years of oral therapy? I'm sure you cannot use the FibroScan for sure. What about ALT flare in compensatory cirrhotics? There is no evidence of high risk of decompensation of cancer, but I would be very cautious. Safety first. I would not recommend this strategy, although this has been used in Asia. Retreatment rates, 40% across all the studies. Very surprisingly, very similar rates. But please remember, early retreatment may reduce the likelihood of S antigen loss, the concept of good flares, whatever is the meaning of good flares. So I strongly believe a stop new control arm may be needed in studies assessing new therapeutics. And the last point, I think, is probably the most important point. What is the best, what's the most desirable endpoint after nuke discontinuation? Do we have an agreement? I'm not sure. Thank you very much for your attention.